Good morning. Today I will present approach to a child with bleeding symptoms for 6-year medical students. This session is presented instead of a clinical session. Suppose that you have it in the hospital because you know of current circumstances of corona pandemic. It's not able for you to attend the hospital and have your clinical session. I will try to present important information from a clinical point of view, and I hope it will be useful for you all. Thanks. Introduction for this topic, we will review the approach to infant, child, or adolescent present with either overt bruising or bleeding or with history of increased bleeding. As you know, bleeding symptoms can occur in healthy children and may not necessarily indicate generalized bleeding disorder. For example, epistaxis may be caused by rhinitis, trauma, oozing from superficial vessel, or dry air. However, symptoms that occur with unusual frequency, duration, or severity, in these cases, we should consider underlying bleeding disorder. On the other hand, if there is abnormal post-surgical bleeding, for example, following surgery like tonsillectomy, circumcision, tooth extraction, it may occur simply due to surgical trauma. However, it may also suggest possibility of underlying bleeding disorder, especially if the child has had a prior history of bleeding symptoms. So clinicians should be alert to the possibility that bruising or bleeding just to be abnormal, depending on frequency, duration of the bleeding, severity of episode, or lack of explanation for symptoms or physical finding that may be caused by bleeding disorder or maybe by non-accidental injury, for example, child abuse. Therefore, the history should include complete details related to degree of symptoms, nature of provoking injuries, and whether such injuries are consistent with child's level of activity. In assessing a patient bleeding history, it is important to ask about prior bleeding episode and characterize the type of bleeding and location. For example, bleeding in the skin and the mucous membrane is characteristic of platelet disorders and their interaction with the blood vessel. This is what we call the purpuric disorders and may be manifested as petechiae and or ecchymosis, while bleeding in soft tissue, muscles, and joint usually suggests the presence of coagulation defects like hemophilia. Family history is very important to be concentrated on in taking history from a patient with a bleeding tendency. Inherited bleeding disorder should be strongly considered when the onset of bleeding manifestations occurs in infancy or early childhood, especially if there is positive family history. But on the other hand, if a child has a mild hereditary bleeding disorder, it may not manifest early in infancy or childhood. It may present later. Please keep this in mind. The presence of a bleeding manifestation only in male sibling and their maternal uncles, al-khawal, is suggestive of excellent recessive inheritance as that seen in hemophilia A or B. However, negative family history doesn't exclude inherited coagulation disorder because 1/3 of patients with hemophilia have negative family history. Von Willebrand disease transmitted in an autosomal dominant fashion and can present in both males and females, while in autosomal recessive disorders such as severe form of rare coagulation factor deficiency, for example, factor 7 or factor 11, the family history may be negative in these cases, but consanguinity increases the probability of such disorders. Another important point in the history to be asked for is medication. A thorough history of medication use, including herbal medicine, is crucial. You know that in our culture, people might use traditional herbal medicine. So always we should ask about these medicines. Also, specific information should be sought about ingestion of aspirin containing over-the-counter medication and other non-steroidal anti-inflammatory drugs. Such drugs will impair platelet function and may exacerbate underlying coagulation disorder. So it's very important to ask about recent use, that's to say within 1 to 2 weeks of this agent, even if they are not the suspected cause of bruising or bleeding in a child, because they cause abnormality in a platelet function test, and this might lead to further unnecessary and expensive studies. Accidental or intentional ingestion of warfarin containing rodenticide can also cause bleeding symptoms in children. In pediatric practice, we come across cases present to emergency room with history of ingestion of rodenticide, قاتل الحشرات والقوارض, and these compounds usually contain warfarin-like substance. So the child present with a bleeding tendency because, as you know, this due to depletion of vitamin K dependent factors. So that's why we should keep this in mind in a child present with acute onset of a bleeding tendency in emergency room. The clinical features of a child with bleeding, we should look for whether bleeding is a single or multiple sites, because single site usually indicate a local cause rather than generalized cause, while multiple sites indicate underlying disorder. Also assess the general condition of the child and his activity and whether he has symptoms like fever, presence of pallor or abdominal distension. History of underlying disease like renal diseases or liver diseases. A male infant who's just started to walk and present with painful swollen joint after a fall is presumed to have hemophilia until proved otherwise. And usually hemophilia starts in this small dependent joint, usually the ankle joints, because of small vessel in these areas. Similarly, unusually prominent forehead trauma in a male infant or young boy is a common presentation of hemophilia, also excessive bleeding after circumcision or other surgical procedures. An otherwise healthy child who presents with petechiae and or mucocutaneous purpura with a history of recent viral infection most likely has acute post-infectious immune thrombocytopenia, while adolescent girl who present with excessive menstrual bleeding, recurrent nosebleeds, and pallor may have von Willebrand disease, which is the most common inherited bleeding disorder. A newborn with bleeding from umbilical stump should be evaluated for coagulation defect. Also, intracranial hemorrhage in an infant without other risk factor should also prompt consideration of bleeding or coagulation defect. These pictures are taken from the hematology lectures given to you in the 5th class. For example, in this picture, you see pictures of a platelet defect, which usually present with petechiae and ecchymosis, mainly in the skin and the mucosal sites, like oral mucosa, the nose, the conjunctiva, and GIT. While coagulation defect usually present with the bleeding inside the joint, hemarthrosis, and hematoma and deep soft tissue. Another picture for a child, you can see petechiae and ecchymosis in the skin, and on the right side, the subconjunctival hemorrhage, which is an example of mucosal site bleeding, and it is a serious sign, herald CNS bleeding. Another picture for a boy with hemarthrosis causing ankylosis of the knee joint and disruption, fibrosis due to recurrent bleeding with atrophy of the muscle of the lower limb. Another picture for vasculitis, which is here in henoch-Schönlein purpura, inflammation of capillaries or small blood vessels. You can see palpable purpuras present, affecting mainly the buttocks and the lower limb. What are the tips on examination that we should look for? We should check and see the nature of bleeding. What do we mean by that? Whether the child has petechial rash, ecchymosis, bleeding from the mucosal sites, muscle hematoma, deep visceral bleeding, because these types of bleeding rash will give us hint to the type of underlying disorder. Associated symptoms like pallor, fever, weakness, loss of weight, as we mentioned, any swelling in the lymph node in the body, abdominal enlargement like hepatosplenomegaly, any other signs of chronic diseases, for example, renal disease or hepatic disease. A renal disease, you might find failure to thrive, pallor, earthy color, signs of ricket, acidotic breathing, as well as bruises due to abnormality in platelet function secondary to uremia. While in hepatic disease, you should look for jaundice, palmar erythema, capillary hemangioma, spider nevi, sites of important signs of portal hypertension like ascites and splenomegaly. Also, edema might be seen. Also look for dysmorphic features, for example, a patient with Fanconi anemia who have microcephaly, microphthalmia, absent thumb, absent radius, cafe au lait spots, pigmentation of skin, and so on. Also a patient with Down syndrome, because Down syndrome is 15 times more liable to have leukemia than normal children. So always check for these dysmorphic features in any child with a bleeding tendency. In this picture, you can see a child with Fanconi anemia. He has absent thumb and absent radius, as well as microphthalmia and microcephaly. A child with cervical lymphadenopathy, and you can see prominent lymphadenopathy in the right side, for example, in a patient with leukemia. Or maybe viral infection like EB virus, which can present with lymphadenopathy and the platelet bleeding tendency secondary to immune thrombocytopenia. We should keep this in mind. Gum hypertrophy is another point you should look for in a patient with a bleeding tendency. It might be seen in patient with aplastic anemia due to hyperplastic gingivitis, or in a patient with acute leukemia, especially myeloblastic leukemia. I will present this case, a 4-year-old boy with history of upper respiratory tract infection 2 weeks ago. It is a sudden onset of appearance of petechiae and bruises. Past history negative, family history negative. Physical examination shows these diffuse pinpoint petechiae. Investigation were done, including complete blood count. It shows hemoglobin 11 gram per DL, white BC 8,000 per cubic milliliter, and the platelet count 35,000. The PT is 14 seconds, while PTT is 33 seconds, fibrinogen 2 gram per liter. These figures are normal. In his blood film on the left side, you can see there is no platelets available, and while on the right side you can see the bone marrow with the presence of megakaryocytes. So what is the most likely diagnosis in this boy? It is immune thrombocytopenia. In a case 2, you are on call for ENT and are asked to see 13-year-old girl with sudden refractory nosebleed. The nose is packed, but the bleeding doesn't stop. And you notice a few bruises. The lab result shows a critical platelet count of 10,000. What is the likely diagnosis? Also, maybe in this case, if there is no previous history, we should think of immune thrombocytopenia, especially with the platelet count 10,000. What to do? This case should be admitted to the hospital because she has continuous bleeding with severe thrombocytopenia compared to the first child who doesn't need admission to the hospital. Just ask the mother to keep the child under observation, and second advice if he develop bleeding. A third case, 14-year-old girl with menorrhagia. She gave history of easy bruises. Her complete blood picture is normal, while PTT is 32 2-second prolonged. It's almost normal, the PTT, but this girl with this history, we should raise suspicion of von Willebrand disease, which is commonly present with mucocutaneous bleeding, especially in girls noticed in adolescence when they have their first menarche. And usually they have the same family history, which might be considered as a normal phenomena, while they have probably underlying von Willebrand disease. So how to diagnose? Of course, by doing a bleeding time, which will be prolonged due to platelet function abnormality with some types of von Willebrand disease, and other by doing the platelet function test and studying the von Willebrand factor, antigen, ristocytine cofactor, and other parts binding part of von Willebrand factor for diagnosis. Treatment, of course, by giving von Willebrand concentrate. When it is not available, we can give sometimes factor 8 concentrate or cryoprecipitate, for example, in our situation when there is no available factor 8 concentrates. A lab evaluation in a child with a bleeding tendency. In fact, there is no single test reliably screens the overall process of hemostasis, especially for abnormality of a platelet function. So the evaluation usually begins with general screening tests to assess hemostasis, and based upon the result of these tests and the clinical suspicion, then additional more specific testing is performed to narrow the possibilities or make a definitive diagnosis. Initial testing include complete blood count and platelet count, examination of peripheral blood smear, prothrombin time with international normalized ratio, activated partial thromboplastin time, APTT, and in some centers they also routinely measure fibrinogen activity by measuring thrombin time. In most cases, we initially obtain all these screening tests, but in certain circumstances, it may be appropriate to perform only limited screening. For example, in an otherwise healthy child who presents with a mucocutaneous bleeding, complete blood count with a platelet count and the examination of peripheral smear are the most informative initial tests. And normal values of coagulation tests may vary with age and among different laboratories. Platelet count and peripheral smear. The platelet count is performed by using automated cell counters, while examination of peripheral blood smear is essential in patients who show low platelet count to exclude the presence of pseudothrombocytopenia due to clumping or aggregation of a platelet. Examination of peripheral smear is important as it may reveal underlying etiology, for example, presence of a blast in leukemia, cystocytes, in a patient with hemolytic uremic syndrome. In addition, it permits assessment of a platelet size, which help to narrow the diagnostic possibilities in a patient with thrombocytopenia, because some disorders are associated with giant platelets. For example, Bernard-Solier syndrome, which is one of the platelet function disorders. Prothrombin time causing production of fibrin via extrinsic pathway and common pathway, which require tissue thromboplastin or tissue factor. It assesses the activity of factor 7, 10, 5, factor 2 prothrombin, and factor 1 or fibrinogen. The PT is sensitive to alteration in vitamin K dependent coagulation factor, which are factor 2, 7, and 10, and is used to monitor the treatment with vitamin K antagonists. While activated partial thromboplastin time, it measures the intrinsic and common pathway of coagulation. It evaluates deficiency of factor 12, 11, 9, and 8. It is less sensitive than PT to deficiency within common pathway, for example, factor 10 and 5 and 1 and 2, and unaffected by alteration in factor 7 and 13. Fibrinogen, functional fibrinogen concentration is commonly measured by using thrombin time. In most cases of a clinically significant fibrinogen disorder, usually both PT and APTT are prolonged because fibrinogen is within the common pathway factors. In some centers, they routinely measure thrombin time as part of initial screening because this test is more sensitive than PT and APTT for detecting fibrinogen disorder. However, other centers do not routinely obtain fibrinogen level if the PT and APTT are normal. Other tests for specific factor deficiencies and inhibitor abnormally prolonged PT or APTT can be due to absence or reduced concentration of coagulation factor or presence of inhibitor. A factor deficiency should be corrected by addition of normal plasma, what we call it mixing study. In this study, we repeat the abnormal PT or APTT after mixing one part of patient plasma with a normal plasma. If this mixture corrects the abnormal test, then deficiency of coagulation factor is likely to be present, but the presence of factor inhibitor is suspected if the abnormal test does not correct or only partially correct after immediate assay of one-to-one mixture of patient and normal plasma. We talk now about a bleeding time and the platelet function analyzer 100. The bleeding time is a measure of a platelet interaction with vessel wall. It is not performed routinely as a screening test in children or adults because it is difficult to be administered in a standardized fashion. Moreover, normal test doesn't predict safety of surgical procedure, so it is not recommended as a screening test prior to surgery, although we are seeing many cases supposed to have, for example, anti-surgery. The surgeon used to send them for a bleeding time, and here you can see that it doesn't predict the safety of surgical procedure. So platelet function analyzer 100 is designed to measure platelet-related primary hemostasis and used as a screening test for investigation of various inherited and acquired disorders of primary hemostasis. So what is the diagnostic approach for abnormality in screening tests? First, if we complete a blood picture showed pancytopenia may be present with or without organomegaly or lymphadenopathy, examination of peripheral blood smear may reveal presence of leukemic blast, suspicion of leukemia arise, and this should be confirmed with bone marrow examination. But another diagnosis to be considered in a child with mucocutaneous bleeding and pancytopenia is aplastic anemia with various combination of symptomatic anemia, bleeding, infection, depending upon severity of it. Single or multiple skeletal anomalies may be present in a child with Fanconi anemia or congenital aplastic anemia. Presence of only thrombocytopenia might occur in association with number of disorders, for example, immune thrombocytopenia. A child presented with normal PT and prolonged APTT, we should suspect intrinsic pathway coagulation factor, which is factor 8, factor 9, 11, and 12. Factor 8 deficiency is the most common inherited disorder, significantly causing prolonged APTT with a reported incidence 1 in 5,000 male, while hemophilia B or factor 9 deficiency occurs less often, 1 in 20,000 male. The hemophilia A is 4 times more frequent than B, and both disorders are inherited as X-linked recessive disorders, with the demonstration of range of presentation depend on severity of phenotype, ranging from prolonged bleeding after surgery or trauma to spontaneous soft tissue and joint hemorrhage. Mucocutaneous bleeding, excessive bruises, prolonged oozing from wounds can also occur. However, you don't expect to see petechiae in these disorders. Keep this in mind. Factor 11 deficiency is seen more commonly in Ashkenazi Jewish and present with variable history of bleeding, which is often mucocutaneous in nature. Lupus anticoagulant are acquired inhibitor that may cause prolonged APTT, commonly seen in children following recent infection, especially viral infection. They are transient and they are not at risk for bleeding nor for thrombosis. Deficiencies of factor 12 usually asymptomatic and not associated with a clinical bleeding. Subjects with this deficiency discovered when asymptomatic child demonstrates significantly prolonged APTT or routine preoperative screening. It can be important to identify because it will provide explanation for an otherwise puzzling prolonged APTT. Now, if we have a child with a prolonged PT and normal APTT, then this indicates inherited or acquired factor 7 deficiency. Prolonged PT and APTT, this, if present in a bleeding child who's otherwise well, it indicates either inherited disorder within common pathway or acquired disorder involving multiple pathway. Inherited deficiency yield this lab result include deficiency of factor 10, 5, 2, and 1. These deficiencies are rare. In a sick child, prolonged PT and PTT, then we should consider a disorder like disseminated intravascular coagulation, fulminant sepsis with DIC, severe hepatocellular dysfunction, and severe vitamin K deficiency. Because the production of factor 5 is independent of status of vitamin K. So assessment of factor 5 will help to distinguish between vitamin K deficiency, in which factor 5 is normal, and liver disease or DIC, in which factor 5 is decreased. Major vessel thrombosis, consumption coagulopathy in certain vascular lesion, and acute respiratory distress syndrome are other rare causes of prolonged PT and APTT in a sick child. For example, what is seen recently in patients with COVID-19 pandemic cases. Accidental or intentional ingestion of warfarin or warfarin-containing rodenticide, as we mentioned, now is sufficient to cause bleeding, will result in a prolongation of PT and APTT because vitamin K dependent factors, which are inhibited by warfarin, are present in extrinsic pathway in form of factor 7, intrinsic pathway factor 9, and common pathway factor 2 and 10. So that's why it causes a prolongation of both PT and PTT. So hemorrhage under the such circumstances may be life-threatening, require immediate treatment with combination of intravenous vitamin K, fresh frozen plasma, prothrombin complex, concentrate, which contain all vitamin K dependent factors. If the patient has normal initial testing with the bleeding symptoms, then possible diagnoses include von Willebrand disease, some cases of hemophilia, factor 13 deficiency, platelet function disorder, vascular abnormality, and fibrinolytic disorder. Regarding von Willebrand disease, it is the most common inherited bleeding disorder with estimated prevalence as high as 1%. We have three major types of it. Type 1 and 3 are a quantitative defect, while type 2 is a qualitative disorder. The lab tests for von Willebrand disease include factor 8 assay, von Willebrand factor activity like ristocytine cofactor assay, and von Willebrand factor antigen. Platelet count may be low in some patients with type 2B von Willebrand disease. Other cases which cause normal bleeding screening tests are mild cases of hemophilia B, in which factor 9 is an activity range of 6 to 40%. This may not reliably result in a prolongation of APTT on initial screening tests due to relative insensitivity of APTT reagent to mild factor 9 deficiency. Also, there exists uncommon form of hemophilia A or 8, in which factor 8 deficiency may be undetectable by using one-stage APTT-based assay used in majority of the lab. So in such cases, a mild discrepant form of hemophilia A may be recognized with use of a special tests like two-stage or chromogenic assay or factor 8 activity. Factor 13 deficiency is responsible for clot stabilization and the cross-linking of fibrin polymer. So deficiency of this factor is an autosomal recessive disorder, result in reduced clot stability and abnormal bleeding. One of characteristic abnormality of factor 13 deficiency is delayed separation of umbilical cord and delayed bleeding from umbilical stump. Also in neonatal period, it presents as intracranial hemorrhage with little or no trauma and poor wound healing. Fibrinolytic disorder like deficiency of alpha-2 antiplasmin and the plasminogen activator inhibitor also associated with increased bleeding tendency. Both disorder of factor 13 deficiency and fibrinolytic pathway disorder cause initial normal screening tests. Platelet function disorder studies to confirm the presence of a qualitative disorder of a platelet function include evaluation of a platelet morphology by peripheral blood smear and tests for a platelet aggregation and other tests for a platelet function. Acquired causes of abnormal platelet function are much more common than inherited causes, including the use of aspirin and non-steroidal anti-inflammatory drugs, beta-lactam antibiotic like cephalosporin, uremia, myeloproliferative, and myelodysplastic syndrome. And as noted above, history of ingestion of the drugs or a platelet inhibitor is critical to be ascertained in a patient with a bleeding disorder, and if a platelet function to be performed, the subject must be asked to stop taking this product at least 1 to 2 weeks before testing. Classic inherited disorder of a platelet function are relatively rare. It includes Glanzmann thrombocythemia characterized by defect in the platelet glycoprotein 2B3A complex. A child presents with significant mucocutaneous bleeding, normally platelet count, but single isolated platelet without any platelet clumping due to defect in aggregation, while Bernard-Solier syndrome characterized by defect in one of the component of a platelet glycoprotein 1B95 complex, causing defect in adhesion, giant platelets, and moderate thrombocytopenia with the bleeding that is greater than expected for degree of thrombocytopenia. This disease sometimes misdiagnosed as immune thrombocytopenia due to presence of moderate thrombocytopenia. Please keep this in mind in a child present with moderate thrombocytopenia not responding to any treatment modality given to a patient with immune thrombocytopenia. Vascular purpura screening test, usually normal in these cases in a patient related to having bleeding related to vascular abnormalities like hereditary disorder of connective tissue, Ehlers-Danlos disease, and osteogenesis imperfecta, or small vessel vasculitis like in immunoglobulin A vasculitis, Hinoch-Schönlein purpura, and psychogenic purpura. Undetermined etiology, when there is sometimes we come across patients with significant bleeding history for which no explanation exists, and physical abuse of child should be considered in such cases. However, some disorders of hemostasis may escape detection with currently available method. Summary and recommendation for this current presentation: evaluation of a bleeding child always begin with careful history, taking into account the child age, sex, clinical presentation, past history, and family history. Bleeding into skin mucous membrane is characteristic of disorder of platelets or their interactions with the blood vessels, while coagulation disorder classically feature musculoskeletal, that's to say muscle and joint and soft tissue bleeding. The nature and extent of injuries producing bleeding symptoms should also be noted. A reasonable initial screening evaluation include complete blood count, including platelet count and examination of peripheral blood smear, PT and APTT, also measure thrombin time to assess fibrinogen level activity. Normal values may vary with age and among different labs. Further testing of specific coagulation factors depend upon history and initial laboratory testing, and these tests often performed to confirm a specific diagnosis of inherited or acquired factor deficiency. If the initial screening evaluation is normal and suspicion remains high for a bleeding disorder, diagnostic possibilities include von Willebrand disease, some form of mild hemophilia, platelet function disorder, and fibrinolytic disorders, including factor 13 deficiency, vascular abnormality as mentioned now, and finally, physical abuse should also be considered. I think we finished this presentation, and I hope it is useful for you. And sorry for the presentation across the net and not in the hospital beside the patient. Nothing will teach us as a replacement for a patient. I hope you success in your final exams, and thanks so much for listening. Thank you.